longer, and what we do know is that there's general underutilisation of services. Even if we provided the best services, and we don't, people would still underutilise them. So pathways to care are difficult. Once they get into care, it doesn't necessarily recognise cultural needs, and we have a whole raft of systems and westernised approaches to the system that don't take account of individual belief systems. I've already touched on the notion of trauma and refugees, and I don't really want to touch too much more about this, except that we know that there's a correlation between PTSD, anxiety, depression. It's cumulative, so the more torture or more trauma that you have, the worse you will be. Refugee camps and detention centres actually compound the issues, and I'm ashamed to say Australia's approach to asylum seekers and refugees is one of shame. Post-migration factors, how does the host country welcome new arrivals? How much discrimination? How much isolation and detachment do people have? How much unemployment, loneliness? And how many people are locked into ethnic enclaves? Ethnic enclaves in and of themselves are very often very good, very helpful because they're a buffer to the outside world, but they can also be problematic because they isolate people. Sometimes in some studies we've found that mental health actually improves over time as people resettle and find their feet. And there are other issues that might mitigate the effects of torture and trauma are religion and gender. And I talked about the dual vulnerabilities. So the people in our services who are from culturally different backgrounds will have the vulnerability of being mentally ill plus the issue around their culture. But the important thing is about westernisation and the westernisation of medicine and mental health universally. Our systems in Australia are based in the Anglo-Celtic traditions and on Western cultural norms. And I guess one of the effects that I wanted to very briefly talk about was the effects of the DSM on the homogenisation and the simplification of mental illness. Just because we name something doesn't mean we can explain it. So we might name something as depression or anxiety, but we don't necessarily explain it by using a diagnostic classification system. In the 60s and earlier, in the 50s, the platypus, for example, was considered a freak of nature. But it was only after we tried to understand and we worked it out that they in fact were a mammal, and that they were a very specific type of mammal and a subspecies of mammal. But it was about trying to work out that. And what we've done through simplification and over-diagnostication and with pathologising of every sort of thing under the sun, that we've made it a worse system than what we had in the past. There's a lot of debate around psychiatric classification systems. None of these are new, and it's nearly always around describing it rather than explaining it. And the danger is the emphasis on description may leave little room for interpretation of psychopathology. The descriptions are drawn from one dominant cultural perspective, i.e. the North American perspective largely, and their cross-cultural universality should be questioned. In these systems, the manifestations of mental illness may be forced to fit preconceived frameworks, and paradoxically the zeal for classification may see more and more human behaviour pathologized. Just so you might have an understanding of the extent of the pathologization, the DSM is now in its 5th edition. Between 1952 and 2015, diagnoses rose 800%, from 106 diagnoses in 1952 to more than 600 now. It's translated into 22 languages. And just because it's translated doesn't mean it's culturally useful. According to Gary Greenberg in 2010, the DSM is an unparalleled literary achievement. It renders the varieties of our psychospiritual suffering without any comment on where it comes from, what it means, or what ought to be done about it. Other criticisms relate to the imposition of a North American Western European perspective on mental illness and the relegation of other cultural perspectives to curiosity status. And in fact, in the DSM-4 TR, it was called culture-bound systems and plonked in an appendices. The mistake that we think we're describing something stable, that they're stable entities, when what we're really being described are socio-political constructs. It further assumes the universality of primary syndromes. The socio-political construction of the DSM, even within its own cultural paradigm, is well illustrated by the fact that the mental disorder of homosexuality was cured with the stroke of a pen, and when it was eliminated from the DSM-2 in 1974. It all coincides with the rise of the biomedical model of care and big pharma. Alan Francis in 2012 came up with a number of specific issues around the DSM-5, and these are the sorts of things that we now have pathologised. Disruptive mood dysregulation for temper tantrums. Major depressive disorder also includes normal grief. Minor neurocognitive disorders for just normal forgetting in old age. Attention deficit disorder in adults. Binge eating. First-time drug users are now lumped in with addicts. Behavioural addictions, making a mental disorder of everything we like to do a lot. And generalised anxiety disorder includes everyday worries. And so what we've got now is a system of pathologising things that we would have considered at some stage to be just regular behaviour. Our role in all of this is to respect cultural differences, acknowledge diversity throughout our attitudes, values and behaviours. To demonstrate cultural understanding, not competence. I couldn't be competent in all of the cultures of the hundreds and hundreds of countries that come to this country, but I can be aware and I can be sensitive. We need to avoid stereotyping. We need to use appropriate resources and seek the help of experts, and that means cultural experts. We need to have multiple worldviews that are considered from consumers, carers, health systems and clinicians. We need to share a worldview and have ethnic similarity. It's very difficult to ethnic match in this country, but if we could, that would be great. We need to be credible by establishing therapeutic alliances, having shared worldviews, acknowledging consumer and carer expectations and mutual decision making. We need to use translated, standardised instruments wherever possible. Use non-standard methods such as journaling to uncover their story. Use the DSM with great care. Explore consumer and carers' frames of reference. Explain everything thoroughly and extend your boundaries. Thank you very much. I hope I wish you well over the next 3 days. Thank you very much.
I have time for 1 or 2 questions.
Transcultural psychiatry unit. You mentioned that through the DSM, ordinary behaviour has been pathologised to a certain degree, and a lot has. Is there some effort being done to unpathologise that what's been put into the DSM back into ordinary behaviour?
There have been, I think if you get onto a number of the websites, and there's been a lot of conversations in psychiatric circles around and criticisms of the current pathologising of basically normal sorts of things. I suppose the cynics would say that because it's driven from the North American model, the insurance companies need to have some sort of diagnosis in order to pay. And of course, then that goes hand in hand with treatment models and those sorts of things. So you've got hugely socio-political players in the huge insurance companies and also the huge pharmaceutical companies who are making a mint, if you like. Some disorders didn't even exist. So, for example, in Japan, depression wasn't even a word for it. And then after a decision by a drug company, there was public outcry, if you like. Before we knew it, the depression diagnoses rose, in the hundreds, and before long the prescriptions of SSRIs were so high in Japan that almost 1 in 4 people were on them. So it's those sorts of things. It's very difficult to argue against those huge those companies. But there are a number of people in mental health who are clinicians, psychiatrists, nurses, other people in allied health who are arguing strongly about using the DSM with great care and looking and understanding why people behave and do the things they do, and getting an understanding of what the symptomatology needs, rather than labelling it and then going down a treatment path which may or may not be useful.
Yeah, thank you very much. I always like to speak to people in transcultural nursing, particularly when it comes to explaining diagnosis to patients. Because we are looking at different perspectives now, different culture, do you explain in terms of the Western orientation or in terms of the culture of the belief of that person? If, for example, I believe, even in my language, there are supposed to be 5 types of, when we are talking about mental illness. But when you look at diagnosis, like 1001, different beliefs, do you explain in terms of the belief of that person, or in terms of what the Western culture, the Western orientation says about diagnosis?
I think that there are two ways to look at that particular question. Firstly, when we explain the system, when people enter the system, we explain it from the westernised perspective, because that's what people are entering into, what's going to happen to them, who they're going to speak to, the sorts of things that are happening with them. What we really need to understand is how well a person can understand English, because the language in Australia is English, and how well we then bring in interpreters to help them understand what's happening for them. Many people can have an everyday conversation around the weather or the trams in Melbourne or those sorts of things, but they're not very good at having clinical conversations. And very, very often, and the best way forward, of course, is to get the expert, the cultural expert, to work with that person, to ask them what they believe, what their expectations of treatment are, what would be the best thing for them, and then to have negotiated outcomes so that we're working in partnership in a therapeutic alliance for that person to have the best outcomes. Unfortunately, whilst that's the ideal situation, it isn't always the way it is, and very often we explain things solely from the Western perspective. So when in fact we don't necessarily even explain, we might say, Mr. Smith, we think you've got depression. And Mr. Smith thinks, oh yeah, what does that mean? And no one tells that person what that means. No one asks that person, what do you understand it means? How do you feel about that? What would you like to see happen? So we do tend to work from our frame of reference, our own frame of reference, which is westernised mental health, certainly in this country. But we need to be much more mindful, because I work currently clinically in an emergency department, and I work as part of the crisis team, and I would see probably 5 or 6 people in any shift, of which the bulk of them will not be Australian born. And so I have to be very mindful about how I speak with those people, how I create the relationship right at the beginning, and their expectations for treatment care. So it does take a lot more time, and that's one of the things. A very recent study said that most GPs would spend only 2 hours in a whole year talking to patients about what their problems were.
Thank you so much, Wendy. Can we just give a round of applause? Thank you so much for we really appreciate that. You've touched on a lot of issues in there that certainly they're food for thought for us, and in terms of our practice as mental health nurses and some of the things we need to be mindful of. So thank you once again for that. Actually, two of my immediate supervisors, so Wendy Cross at Monash, but I've also got Shelley Anderson, who is the manager of the Alfred Psychiatry Workforce Development and Education. So Shelley is going to welcome us to the Alfred. For some of us who don't know, Alfred Hospital is one of the largest